Morning, good afternoon, and good evening. Ladies and gentlemen, dear friends and colleagues, wherever you are, I'm Professor Akhtar Hussain, President-elect of the International Diabetes Federation and Chair of the International Diabetes Federation's Education Committee. It is my great pleasure to welcome you all to today's live webinar, where we will spend the next 75 minutes discussing the evolving landscape in the management of type 2 diabetes. Here, I would like to tell you that today's landscape of diabetes, I often say the rule of 50%. 50% of the people are not diagnosed. 50% of the people, those who are diagnosed, receive treatment. 50% of those people that who receives treatment actually achieve the glycemic control. And those people who achieve the glycemic control, only 50% actually can get free from the complications. We have a huge challenge ahead, even after 100 years of insulin use as a therapy. We are still at this state and we need to see with our fresh eyes. The first two webinars scheduled for 2021, this webinar series is the part of the IDF School online course in the management, prevention of cardio-renal complications of type 2 diabetes. The online course and the webinars are supported by an education grant from AstraZeneca as a part of AstraZeneca's Take Care of Me program. Thank you for taking the time to be here today with us. Today is all about uncovering the latest evidence-based pharmaceutical management, early diagnosis, and prevention of cardio-renal complications in type 2 diabetes. We'll be addressing the following topics. Firstly, we'll discuss the use of data to transfer diabetes care and the life of people living with diabetes, like drawing work that helped deliver the Lancet Commission report of diabetes. Then we'll explore the cardio-renal benefits of AGL2 inhibitors. Before our last speaker will give an overview of the evidence in practice, with us today, we have a distinguished panel of leading experts in their respective fields. I welcome Professor Julian Chan, Hong Kong, China, Professor Rupa Mehta, Mexico, Professor João Felipe Rapso, Portugal. We are honored that you can be here with us today to share your vision and insight into the evolving landscape and the management of type 2 diabetes. Before I get started, I'm going to go through some housekeeping to help you interact with our speakers. At the end of the webinar, we'll be running a live question and answer session so that we have enabled our open chat feature. If you have any questions for our speakers, just pop them into the chat, and this will be shared with our speakers at the end of the session. And if you miss anything, don't worry. We will be sending around on demand recording once available. The webinar recording will also be available on the IDF School of Diabetes platform. For those of you just joining us, welcome, and I wish you an excellent session. Let's get straight into the content. Professor Chan, welcome. The floor is yours. Thank you.
Thank you, Professor Hussain, for the introduction. And I'm Dr. Juliana Chan from Hong Kong, and I'm very honored to be part of this webinar and really reviewing, the evolution of evidence and the latest guideline in the management of diabetes. So let me share my slides, okay? Okay, so let me see. All right, okay. So you can see my slides. So what I'm going to talk to you as really setting the scene is a brief report of the Lancet Commission report on diabetes, where we advocate using data to transform diabetes care and patient lives. We are living in an era of, these are my disclosures. We are living in an era of evidence And really over the last 30 years, we have really learned a great deal about diabetes. During the evolution of evidence, obviously we did a lot of epidemiological studies. We have a lot of observations based on which we have derived multiple hypotheses. And then, we carry out experimentation, particularly in the form of clinical trials. And then with the consistency of the clinical trials, that formed the basis of guidelines. Another way of actually, influencing practice is sometimes there are innovative strategies which might be context relevant, but with the evaluation and the reports, this might also influence other researchers or policymakers, for example, to adapt the strategies. And then there will be another consistency in terms of this evidence. And so, it is the consistency of this data that actually form the basis for guidelines. And then these guidelines will hopefully be implemented to improve outcomes, and that forms a global trend. And I think in the field of diabetes, we really have gone through, a lot of these stages, and we have no shortage of evidence. But I think some of the missing, gaps is really the implementation. I think here, we very often look towards the American Diabetes Associations, which really provides, a update regarding the latest evidence every year. In January, they would actually publish the standards of medical care in diabetes. And I just thought, I highlight these chapters to really highlight the complexity of the subjects. We are really not just talking about personal health, but also, global health. And therefore improving the care and promoting health in the population. There are now increasing evidence regarding the heterogeneity of causes, and which really call for better classification of diagnosis of diabetes. Of course, we all want to prevent or delay diabetes. And once people get diabetes, we need to do comprehensive evaluation, assessment of comorbidities. Diabetes a lot relates to behavior. And so we also need to learn how to help people change behavior, facilitate behavioral change, and promote well-being in order to improve outcomes. The glycemic target is obviously central to the management of diabetes, and we now have a lot of technology to help us achieve that. Obesity is another major challenge. And again, this involves both behavioral strategies, but also there are now technologies that can help us to manage this. Of course, pharmacological therapy is very important because, after all, diabetes is a complex biomedical disease, and for which we now understand a lot, and for which drugs have been sort of developed, and many of them have been shown to reduce cardiovascular disease and also, to reduce the risk. And not only are we talking about cardiovascular, renal complications, microvascular complications are very important. And of course, diabetes affect all ages. And also, we're dealing with older adults, we are dealing with children, adolescents, and of course, the pregnancy. Pregnant women are also part of this life course management of diabetes. And finally, people who get admitted to the hospital, care is also, management of diabetes also requires a lot of evidence-based strategies. And finally, like what IDF is doing, we need a lot of advocacy, because to really prevent and control diabetes, we need really multi-sectoral partnerships in order to do that. Apart from the ADA guideline, we've also have the IDF clinical practice recommendations that was published, and focusing very much on how to screen, how to diagnose, and how to achieve targets. Again, the review of the pharmacological treatment, and then also the idea is to reduce cardiovascular risk and complications. A particular point that we really need to be aware of is the rising burden of chronic kidney disease, which are tightly related with cardiovascular disease, particularly in many of the emerging economies, particularly like Oceania, Central, Latin America, Africa, and Central Europe, etc. And you could see that actually the age-adjusted disability lost years is tremendous in these areas, the chronic kidney disease and also the cardiovascular diseases. And it is good that we now actually have new strategies and new technologies that we can actually control these diseases. And it is against this background that, last year there was this KDIGO guideline, which has been published, targeting, reviewing the latest evidence regarding the treatment of chronic kidney disease in patients with diabetes. and we're going to hear a lot about this, but you'll be reminded, how we're going to grade chronic kidney disease by eGFR as well as by albuminuria, and that's, really the control of glucose, blood pressure, lipid, as well as lifestyle, exercise, nutrition, and smoking cessation from the fundamental, they are the fundamental in the management. But of course, now we have not just the RAS inhibitors, but the SGLT2 inhibitors, which have very strong evidence to support, their role in reducing, the decline in kidney function and endpoint. And some of these people obviously have cardiovascular disease and atherosclerosis, who might also benefit from antiplatelet strategies. And we now actually, the new paradigm in the management of chronic kidney disease is now, it's not just glucose lowering, but really organ protection. So apart from lifestyle therapy, the first line therapy now is really metformin and SGLT2 inhibitors, and really depending, the continuation of which is much guided by the eGFR, and we'll be hearing about this later on from the other two speakers. And then, of course, these are for the organ protections, but many of these individuals will still need additional glucose-lowering drugs in order to reach the targets. And this is really where a lot of individualization comes in, taking into consideration context and the pathophysiology and also the risk factor profile of these individuals. So it is against this background, that a group of experts, not just in clinical medicine, but also public health and also health economics and also epidemiology came together in 2016, and who has spent actually 4 years to review the literature, the evidence regarding the whole spectrum of diabetes, all the way from health promotion, early detection, disease prevention, personalized care, self-management, care and rehabilitation, and focusing on how do we really implement the practice guideline integrating both primary and secondary prevention. And our conclusion is data is really very important given the fact that this is a very silent disease, it's progressive, and there's a lot of changes throughout the life course of a person with diabetes. And that ongoing data collection, evaluation, and feedback are very powerful in influencing, in empowering the individuals for self-management, as well as informing the care providers to delay, to avoid treatment inertia. But collectively, that data can also inform, decision makers in order to put the resources in place and reforming the system to make sure, that these people with or at risk of diabetes are having the services and also the support that they have, that they need in order to reduce complications and also to reduce the occurrence of diabetes. In this Lancet Commission report on diabetes, we have highlighted that 6 key evidence-based recommendations based on really 30 years of global efforts. And that is if we can reduce A1C by 0.9%, systolic blood pressure by 10 millimeters of mercury, LDL cholesterol by 1 millimoles per liter, or a combination of these risk factors reduction, we can independently reduce the risk of cardiovascular disease, all-cause death by 10 to 20% in patients with type 2 diabetes. And reducing multiple risk factors, including the use of statin and renin-angiotensin system inhibitors, can again independently prevent cardiovascular renal events by 20 to 40% in individuals with or at risk of having diabetes. Very encouragingly, over the last 5 years or 10 years, we have accrued a really large body of evidence, supporting the use of SGLT2 inhibitors and GLP-1 receptor agonists, which can again reduce CV renal events and death up to 40% in certain situations, independent of the effect of reducing blood glucose. However, the challenge is how do we actually, give these technologies to our patients at the right time and for the right reason. And the use of data-driven, team-based integrated care, again, based on evidence through organization of healthcare provision can reduce these adverse events by 20 to 60%, because we need to create that environment and also that processes and also that human resources to identify these patients early and to actually administer treatment and to make sure that these patients stay on the treatment to get the benefit from this treatment. Also, a piece of evidence is, of course, for obese people, particularly if they have diabetes within 6 years, and we can reduce the obesity by 15 kilograms, we can actually cause remission of the diabetes for up to 2 years. And of course, implementing a structured lifestyle intervention and use of metformin can actually prevent or delay type 2 diabetes in people with impaired glucose tolerance by 30 to 50%. So these are the 6 key evidence recommendations that we need to actually implement in order to make a difference to the people with diabetes or at risk of having diabetes. However, we do realize that actually there are tremendous gaps in terms of prevention, care, and data and professional knowledge. And these kind of webinars organized by different organizations and IDF are very, very important to disseminate that knowledge in order to implement this evidence. Just to, in this report, we've also did a lot of modeling to really, estimate the impact of implementing evidence. Type 1 diabetes, of course, very, very important, although the number of people are less compared to type 2, but many of these are very young people, and they are very, very treatable. But even, we are not in the 100 years of insulin discovery. Many people are still denied these life-saving medications. So in this report, we estimated in 2017, 1.6 million people had diabetes, type 1 diabetes. Unfortunately, nearly 15,000 young people died. But this 84% of these deaths can be prevented in all these regions. You could see if these people are given basal bolus insulin regimen, if they have access to self-monitor blood glucose monitoring tools, education and complication screening. So we advocate not just the insulin, but really a total package, the education, the monitoring tools, and the assessment. And you could see that, particularly in some areas, the reduction in these death rates, can be markedly reduced only if we can put these technologies and services in place. The challenge of diabetes, the exciting thing about diabetes, it is actually preventable and treatable. And in this report, we've demonstrated that really there are in places where there are actually data. So the data are really generally very encouraging. So of course, many of these data are coming from high income countries, but really over the years, you could see that, in almost universally, once, where universal healthcare system, medication, support system are put in place, there is actually declining mortality rates. And so we just need to actually extend this phenomena to many, many other countries. So there are enormous amount of opportunities for improvement. So in this report, based on a lot of evidence and data, we estimated that, for example, the top 10 countries, these are the top 10 countries in the so-called developing areas, okay, about 3 million people with diabetes have died, okay, in 1 year, in 2019. And about half of these are actually due to cardiovascular diseases. But if these people actually are, if in these patients, if we can reduce the systolic blood pressure by 10 millimeters mercury, particularly in people who have high blood pressure and also reducing cholesterol, we can actually prevent nearly 1 million deaths just by making sure, that these essential medications are reaching out to these individuals. We can already make a difference. We know that actually managing diabetes is very challenging. We are really dealing very complex interactions among some of the demographic data, the education, the socioeconomic status, the age, the sex, the ethnicity. The age of diagnosis is very important. It determines the duration of diabetes. The family history, which might be genetics or it might be shared environment, adds in a very complex manner to give rise to these 4 risk factors. And then this will again interact to give rise to generalized vasculopathy, inflammation, and this will give rise to these comorbidities of cardiovascular renal complications, cancer, depression, and multiple morbidities. However, this can happen over 20, 30 years. However, this can be totally averted if these people have access to care, education, self-management, and ongoing support. But of course, we need to have all these systems put in place, including societal factors, primary care, and also specialist care and hospital care. So these are really some of the RCT really showing that some of these quality improvements, again, on top of whatever usual care, you can actually reduce A1C by 0.3% to 0.2%. And these are really strategies targeted at either, the system and also, or the patient or the clinician. But most importantly is really the team change, okay, and also the education and the self-management, which have the largest effect. So again, using modeling, using, for example, China's example, where again, like what Professor Hussein was saying, only 50% were diagnosed, okay, of these 70% were treated. If we can achieve this, on top of this, if we can actually implement integrated care and then reduce A1C, reduce LDL cholesterol and A1C, we can actually again prevent nearly, nearly 1 million deaths, cardiovascular diseases in these areas. So in this report, we actually put out, very detailed plan of implementation, setting up centers, particular specialist center to support other teams, and also implementing certain plans to set up registers in order to close these gaps. A lot of these registers, they provide assessment, they provide empowerment, they gather data, and the data can be linked to population as well as hospitalization data to actually assess what we have been doing and in order to measure the outcome and also, to influence practice. And again, in the register, in this report, we have outlined some of the data points that we need to systematically collect, at diagnosis and maybe every 2 years or so to provide quality assurance. So putting people up on the register, we can start actually using stratifying risk, and then we will be able to review the risk factor control and then relay that information to both the providers and the patients and to reinforce, treatment compliance and self-management. And most importantly, to ensure that these people do not default and then, and so that, they don't come back in a few years with a lot of complications. And our goals are really self-management, treating to multiple targets, and also ensuring that they are on these organ protective drugs with ongoing support. And in certain centers, if they have the capacity and the support, then these data are very, very informative on a population basis. If they can be linked to population surveys and also hospitalization data, then we can actually start identify high-risk individuals and also the value of these drug medications and services in terms of reducing hospitalization mortality. And that will also help decision makers to plan for the service in order to improve outcome. So really, I think in the proposal, we were saying that, given the magnitude of diabetes as a population challenge, we obviously need societal strategies, which really very much in keeping with the Sustainable Developmental Goals of the United Nations, ensuring ensuring universal education, reducing social disparity, and also to protect the environment. At a community level, okay, this is really trying to do primary prevention. Of course, a lot of the healthcare policies is needed to create a health enabling environment, to encourage physical activity and also to encourage healthy diets. Particularly, universal health coverage is very important in order to reach the WHO framework for control of NCDs. And of course, at the individual level, this is really where the integrated care comes in, where we will, with that support, then we'll be able to implement the professional practice guideline. And of course, we recognize the importance of maternal obesity and the gestational diabetes and their impact on the offspring, and which is, of course, driving some of the youth onset diabetes. And therefore, the maternal and the child health is also a very important part in the prevention of diabetes, particularly the perpetuation of the transgenerational of diabetes. So in this report, we did modeling and then really estimate if we can actually implement all these strategies, including community-based as well as individualized sort of treatment, then we will be able, for example, for 1 million adults, we will be able to prevent, after 10 years, 22,000 cases of diabetes and 17,000 cases of cardiovascular diseases. And this number will further increase after 20 years. So for a population such as China with 1.3 billion people, we'll be able to prevent 44 million, cases of diabetes and 67 million of cases of cardiovascular diseases. So we hope that actually in this Lancet report, we hope this will serve as an advocacy document to really drive some of the implementation, focusing on the use of data to assess, to measure, and to monitor, and particularly using it to educate and empower individuals in order to make sure that what we're going to hear later on in these two talks, all these new medications that we are going to give to the patients, that they can really get the benefit. So you're welcome to watch this Lancet webinar as well. And for that, with that, I would like to pass on, the floor to our next speaker. Thank you. So our next speaker is Professor Rupa. So he's going to talk about the treatment of the SGLT2 inhibitors.
Thank you very much, Professor Chan. That was a great talk. I'm not sure how I'll follow on from that, but I wanted to start off with having some polling questions initially so that we can have a more interactive session. So could I ask the technical staff to put up the first polling question, please? Okay, so the first question is, how frequent do you see cardio-renal complications in type 2 diabetes patients in your clinical practice? So if you could vote for this, is this less than 10%, 10 to 20%, 21 to 30%, 31 to 40%, 41 to 50%, or greater than 50%? So please vote. I'd love to see what really happens in your clinical practice. There's no obviously correct answer. It would just be interesting to see that across the region, what are we really seeing with respect to complications? Okay, I think we're just about to have a look at the results. So if you could put up the results for me, that would be fantastic. Okay, so what we're seeing here that it's quite a range of answers here. So the most popular answer was 21 to 30% and also 41 to 50%. So these were the most common answers, but as you can see, it's across the range. So I think each country must have its challenges with respect to the amount of cardio-renal complications they see in their diabetic patients. It's ranging from a very small amount to some countries even, or some participants really reporting up to greater than 50% of their patients. So again, this reinforces what Professor Chan has been commenting. We need these new medications that could have an impact on these complications. Technical team, can I have the second polling question, please? So what is the place of SGLT2 inhibitors in my practice? Is it for glucose lowering effects followed by cardio-renal benefits? Or is it the other way around? Is it for cardio-renal benefits followed by glucose lowering effects? Or am I concerned about the safety profile? So what is the place in this case of SGLT2 inhibitors? Are we putting more emphasis on their glucose lowering effects, or are you really considering their cardio-renal benefits, or are you still concerned about their safety profile? Please vote. So let's have a look and see what the answers were. Okay, so it's a fair 50-50 split. So many of you are using this class of drugs because it's a glucose lowering agent, and if it gives you a cardio-renal benefit as well, that's great. And others of you are now Oh, right. So that's changed. So now 64% are saying it's more for the cardio-renal benefits we can get independent of the glucose lowering effect. And I'm so happy to see that 0% are really not concerned about the safety profile. So again, what Professor Chan was also emphasizing, it's not just access to these new medications, it's also use of these new medications to prevent complications. And that seems to be the case. So I'm going to now share my presentation with you all so we can get started. So in the end, I ended up changing. Right, so can you all see my presentation? Can you see the presentation now? Can someone, Dr.
No,
Professor? You can't?
I cannot see.
Okay, let me just go back and share it again. Right, can you see it now?
Yeah.
Yeah.
Yes?
It's okay. Yeah.
Thank you so much. Okay, so I changed the title of the talk. I decided that, we need to also talk about the other class of newer medications that we use for glucose lowering. So the title now is Cardio-Renal Benefits of the Newer Glucose Lowering Agents. And really, I'm concentrating not just on the SGLT2 inhibitors, but also the GLP-1 receptor agonists. So I'm going to try and, oh dear, it doesn't seem to want to change. There we go. So that was my disclosures slide. So this is the first slide I'm showing you. And I think this is really exactly where we are with respect to the management, or at least the selection of glucose lowering agents for diabetes care. So the current guidelines, as I'm sure you're all aware, have changed significantly from recent years. They're now telling us that obviously it's a more personalized approach where we avoid clinical inertia, where we try and help adherence in our patients, but still the first line agent is metformin. And then if our patients have indicators of high cardiovascular risk, chronic kidney disease, or heart failure, then we look at the left-hand side of this algorithm. And if not, we then assess other factors such as hypoglycemia risk, cost, or weight. So just concentrating on the left-hand side, remember again, the ADA guidelines, we're focusing on the best glucose lowering agent options to control our diabetes and prevent complications. So you can see that really these newer agents, the SGLT2 inhibitors and the GLP-1 receptor agonists, we're advocating to begin these agents in these high-risk patients. And all this comes from the CVOT studies that have been presented and published in recent years. So I know you're all aware of this. If we look at the cardiovascular guidelines, or not the cardiovascular, but the guidelines endorsed by the cardiology societies, there was a little change here. Remember, it's because the focus is very different. The focus is on cardiovascular risk reduction in diabetic patients. So here, what the general message is, that really we don't need to start with metformin. What we need to do in these patients at high or very high cardiovascular risk is begin one of these two classes of medications independent of metformin. But again, this is because the focus is on cardiovascular risk reduction. And Professor Chan has also mentioned the latest renal guidelines changing as well. They now endorse SGLT2 inhibitors as second-line agents in patients with type 2 diabetes and renal disease. So this is where we are now with respect to guidelines and what is recommended for diabetes management. But all of this has been based on CVOT evidence. So remember, CVOT studies are really for cardiovascular safety more than anything else. But as you all know, the recent studies have shown these additional cardiovascular and renal benefits, and this is why the guidelines have changed. But the rest of this talk, I'm actually going to sit down and just go through recent evidence, okay? Because we all know the CVOT evidence. Since that time, newer studies have been published, and I'm just going to try and get you up to date so you can understand as well why this cardio-renal benefit is what we should be really looking forward to in our patients. So I thought I'd divide it up into the heart and kidney, because these are the two areas where the latest evidence is, and then show the evidence for each class of medication. So let's start with the heart and the GLP-1 receptor agonist. So really the only evidence we have up to date with the GLP-1 receptor agonist and the heart comes from meta-analysis or newer analysis of the CVOT trials. So this was a recent article published in Lancet Diabetes and Endocrinology, and it shows us a meta-analysis of the 8 GLP-1 CVOT trials that we all know. So this included more than 60,000 patients, and in the pooled analysis, treatment with a GLP-1 receptor agonist led to a 14% relative risk reduction in MACE. So this kind of supports what we found in the individual studies. Remember, meta-analysis data, if there isn't a high degree of heterogeneity, can help us decide if these class of medications should really be advocated for these outcomes. So there is a definite signal that GLP-1 receptor agonists have an impact on risk reduction in MACE. The number needed to treat was 65, and this was over a weighted average median follow-up of 3 years. You can also see on the forest plot results for cardiovascular death. And here again, we're getting a hazard ratio of 0.87. So again, the GLP-1 receptor agonists seem to have a positive benefit with respect to cardiovascular death as well. In the rest of this analysis, they looked at the individual components of MACE, so fatal and non-fatal myocardial infarction. We see a 10% risk reduction, and with respect to fatal and non-fatal stroke, which was always the strongest signal with GLP-1 receptor agonists, again, a hazard ratio of 0.87. That's a 17% risk reduction. They also looked at other secondary outcomes that were looked at in the CVOTs, so hospitalization for heart failure, and this was reduced by 11%. However, the number needed to treat was quite high, 258. So this is not such a strong signal as we get with the SGLT2 inhibitors. And in general, when they divided them into human GLP-1 receptor agonists versus exendin-based, it was evident that it was the human GLP-1 receptor agonists that showed greater cardiovascular benefit than exendin-based compounds. So this most recent meta-analysis supports the guidelines, supports what we've seen in the individual CVOTs, and does show us very clearly that there is a positive effect on cardiovascular outcomes with this class of agent. If we now turn our attention to SGLT2 inhibitors in the heart, so here we've had new evidence coming to light with newer studies having been published. So let me briefly go through the results of these studies. So we know with the CVOT studies, with the secondary outcomes, there was benefit with this class in heart failure. However, there have now been studies looking at reduced ejection heart failure, and they've shown a benefit. I'm showing you here the two most recent studies with dapagliflozin and empagliflozin, both in similar populations with reduced ejection fraction heart failure. And you can see the primary outcome on this table in blue, and they show a very similar level of evidence, a clear benefit in the primary outcome with a risk reduction of 25%. If we look specifically at the two individual studies, there were some differences or appeared to be differences. Empagliflozin showed additional benefit in secondary renal outcomes. You can see here a risk reduction of 50%, and dapagliflozin showed additional benefit with respect to all-cause mortality and cardiovascular death as well. I have to stress that in these studies, there were populations with and without diabetes, and the benefit was independent of diabetes status. So these do suggest that there might be differences in the primary outcome, no differences between these two agents. However, a recent meta-analysis has shown us that I think we can consider the benefits that we're seeing with SGLT2 inhibitors as a class effect. So if we look at this recent meta-analysis, they look specifically at cardiovascular death, and they looked at EMPEROR-reduced and DAPA-HF, and you can see very clearly that they're all in the same direction. There is a risk reduction with respect to cardiovascular death and obviously for heart failure. But again, let's look at the renal outputs, and we can see that both, if we do the meta-analysis, the overall pooled result is that there is a benefit with both these agents. And there was little heterogeneity, so that's important. So that's with respect to reduced ejection fraction heart failure. Let me show you the most recent study, EMPEROR Preserved. This was in subjects with preserved ejection fraction greater than or equal to 40%. Here I've shown you the inclusion criteria, 26 months of study with a dose of empagliflozin 10 milligrams. Primary outcome, hospitalization for heart failure or cardiovascular death, which is what I'm showing you in the graph here, with a 21% risk reduction in favor of empagliflozin. Again, similar results in patients with and without diabetes. And when they looked at the individual components of the primary outcome, it was mainly driven by hospitalization for heart failure. There was a reduction of cardiovascular mortality, but this was a non-significant 9% lower risk with empagliflozin. So I think it's important that we look at other aspects. There was an analysis of renal outcomes in EMPEROR reduced and EMPEROR preserved trials. And I think you can see here with both these graphs, the benefit is more marked in EMPEROR reduced. There seemed to be a lack of benefit in EMPEROR preserved. However, the annualized decline in eGFR was more marked in the placebo group than in the empagliflozin group in both studies. But when we look at the mean adjusted differences, this was nearly twice as great in EMPEROR reduced than in EMPEROR preserved. And again, was similar in patients with and without. Again, this suggests that this renoprotective effect, it seems to be a class effect, but we see it more if we're looking at heart failure patients in reduced ejection fraction heart failure rather than preserved ejection fraction heart failure. So I think this was an important sub-analysis of both these studies. So I think I've shown you with respect to the heart, what we have to date with GLP-1 receptor agonists is meta-analyses of the CVOT studies, but we now have new data in heart failure in the SGLT2 class. But let's look at the kidneys and the GLP-1 receptor agonists. Again, no new data. This is again the same meta-analysis, and we can see here the reduction in the composite of kidney outcome of worsening kidney function, kidney replacement therapy, and kidney death, including development of macroalbuminuria, was reduced by 21% in favor of the GLP-1 receptor agonist, with a number needed to treat of 47. However, you can see clearly in the forest plot that there wasn't the same benefit in worsening of kidney function. It was in the composite kidney outcome. So GLP-1 receptor agonists reduced the risk of the broad composite kidney outcome significantly by 17%, and this was driven by a reduction in macroalbuminuria. This is another analysis of the same. And the cardio-renal benefits of GLP-1 receptor agonists may be partially mediated by other aspects, the glycated hemoglobin, the blood pressure, weight loss, and other CV risk factors. This meta-regression analysis that I'm not showing here but has been published has suggested that there's a linear relationship between the degree of lowering of glycated hemoglobin level and the hazard of MACE or stroke with GLP-1 receptor agonists. But the benefit in renal outcomes, which is what we're looking here, may be due to endothelial or microvascular effects. But again, I'm stressing it's mainly in the composite outcome. It's driven by macroalbuminuria, and we're not seeing such a great benefit with respect to worsening renal outcomes. So the GLP-1 receptor class, I don't have any new renal data to present to you. But if we look at the SGLT2 inhibitors, again, let me go back to the CVOTs. There was a clear signal, and it was very significant in all the studies, over 40% risk reduction with respect to secondary renal outcomes. And I'm showing you here the three main studies. But again, you can't compare them because they had different inclusion criteria, different mean eGFR, different proportion of macroalbuminuria. So that was the reason dedicated renal outcome studies have been presented. And the first one was the Credence study. So the Credence study was really the first study to look at renal outcomes in diabetic patients. And these were patients with diabetes, an eGFR between 30 and 90, and macroalbuminuria. The primary composite outcome was doubling of serum creatinine, end-stage renal failure, or renal or cardiovascular death. and we can see a 30% risk reduction in favor, in this case, of canagliflozin. And I've put the credence study next to the other outcomes in the CVOT studies, and you can see it's in the same direction. There was also a 32% risk reduction in end-stage kidney disease as well. So I think the little table at the bottom of this slide is important to take into account, because it shows us really the DECLARE, CANVAS, and PEREG were really in patients with mild renal deficiencies. If we look at the credence study, we're looking now at patients with macroalbuminuria and more advanced renal disease. However, then other newer renal outcome trials have been designed, and the question here was that they saw the benefit in the CVOTs, they saw the benefit in credence, and the rationale was to explore if this class of medications would have similar benefits in people without diabetes and possibly more advanced kidney disease. So we've just had the publication as well last year of DAPA-CKD. Here, 67% of the patients had diabetes and the rest of the patients didn't. And we can see here with the result, again, it's the same kind of table I'm showing you compared to credence, primary outcome in blue. And we can see very clearly there was a reduction in risk of kidney failure, a reduction in risk of CV death or heart failure hospitalization, and prolonged survival. And this benefit also extended to a broader population, not obviously just the diabetic population, but also patients with glomerular disease and also IgA nephropathy. And there was a reduction in all-cause mortality as well. So this renal outcome data up to now has shown a clear benefit of this class. We're still waiting for EMPA-Kidney as well, which is looking at patients with habitant eGFR going all the way down to 20. So again, I think it's very clear. The SGLT2 class and its benefits in renal disease go beyond type 2 diabetes, and this has been very important, obviously, for the nephrology world in instituting these medications for prevention. So when we think about right now the totality of evidence for the SGLT2 inhibitors, I liked this slide because it's just emphasizing again, we see benefit in heart failure. It's very clear we see benefit in kidney outcomes, and this is in patients. We've got the vast evidence in diabetes, but we now have significant evidence in patients without diabetes. So this class is moving beyond the diabetes world. If we think about, between the two classes of medication, which gives you the greater cardio-renal benefit, there's been a recent study really looking at an analysis from the Swedish nationwide database, and it was used to capture cardio-renal outcomes. Propensity score and matching was used, around 22,000 patients, and a follow-up of almost 2 years with the GLP-1 receptor agonist, 1.2 years with the SGLT2 inhibitors. And I like the table more than anything else because I think it's very clear. If we look at the GLP-1 receptor agonist and the SGLT2 inhibitors, similar with respect to risk of MACE, acute myocardial infarction, and fatal CVD. So the cardiovascular benefit of both these classes is very evident. If we look at these outcomes on the table, you can see that really the p-value, it's not significant in general. So there doesn't seem to be favor of one more than the other in a significant manner. However, if we look at other outcomes, the GLP-1 receptor agonists are associated with lower risks of stroke and also peripheral arterial disease, again, supporting what we know from the CVOTs. And there is some hint of lower heart failure and total mortality in the short term in those prescribed SGLT2 inhibitors. So where does this leave us? This analysis shows us very clearly both classes have cardio-renal benefits, both classes show cardiovascular benefits. Maybe the individual classes have benefits in a particular type of patient that still needs to be explored. But in general, it's really emphasizing again, and I think it's echoing some of what Professor Chan has been telling us earlier, that this cardio-renal metabolic approach is becoming really the status quo for our patients and will become more important because we can see, as this diagram shows us, if we want to tackle all three of these areas, we need a comprehensive prevention approach. We need weight management, we need exercise, we need blood pressure control, lipid control, adequate glucose control using these newer therapies. I've shown you both classes have benefits, adding in ACE inhibitors, and thereby we will reduce morbidity and mortality. But we still need to explore these novel cardio-renal mechanisms in other maybe mechanistic studies in the future. So with that, I'll finish. Thank you very much for your attention. Thank you again, IDF, for inviting me to participate in this session. I'd now like to pass it on to my colleague, Professor Zhao. Please get started. I don't want to delay you any further.
Thank you so much. It was a great presentation, Dr. Mehta. Hello, Professor Juliana Chan. It's also nice to be here with you and with Professor Akhtar. A special greeting for the IDF team, especially to the IDF School, and to Professor Akhtar Hussein for leading this education committee. And greetings to all the colleagues that took this Saturday to be listening to us. I know that we have a huge audience, and I hope you take the chance to make the questions, so we'll have some time at the end to discuss. And without further ado, let's try to share my presentation and share my point of view on this. So, okay, I hope you are seeing it. And my talk would be about evidence in practice. And actually, I think we are quite aligned between ourselves with our perspectives on this new approach on diabetes. But let me just try to say something a little bit different, perhaps. So those are my disclosures. And so I also tried to change my title that was of this talk, that was evidence in practice. And so I changed it from clinical trials to guidelines to real life, what we know, what we don't know. And I'll try to structure it around this, again, a little bit discussion on building guidelines, implementing the guidelines, a couple of words on clinical inertia, what outcomes and with which tools can we deliver and achieve those outcomes. So about building guidelines, and Professor Chen already told us how usually we collect evidence and published guidelines and recommendations. And this is another scheme that you can see. The information comes from studies, systematic reviews, synopses from the systems, and we publish as research, guidelines, journals everywhere. And with that, what are our purpose when writing guidelines? So also from 15, 16 years paper about the potential benefits, and we have to see three different perspectives. So when we use evidence-based guidelines, and in practice, if we implement those guidelines, we have potential benefits for patients, as we have seen there, better quality of care, improve outcomes, improve consistency of care, empower patients to make more informed choices, influence public policy. But we also have potential benefits for the healthcare professionals, better quality of clinical decisions, reassure the clinicians that their practice is appropriate, provide explicit recommendations to guide care, reduce outdated, ineffective, or wasteful practice. But there are also potential benefits for the healthcare systems to improve efficiency, optimize value for money, and that I think there are quite good arguments so we can create awareness of the need to implement guidelines, because there are clear demonstrations of benefits to patients, healthcare professionals, and for the healthcare system. And so let's speak a little bit about data. And it's quite an old study, that's UKPDS and a follow-up study. And it's also to introduce for this discussion the concept of time. When we are speaking about data and data in diabetes, we know that sometimes the information, and now we have access to these cardiovascular outcomes trials that have demonstrated for the new drugs quite important results that many of them were not expected like 5 years ago. But we also have to know, and we know that at least since the UKPDS, that time can be an important drive also to achieve other kind of results. Sometimes also good results come at a later stage. And so as you can see, the red dots here are the results at the end of the UKPDS, and then we'll have the results for the follow-up period. And you can see that even for most of the drugs, we have a benefit for the myocardial infarction and for death from any cause that were not so evident at the beginning. So that's just a caution for when reading data. Another example of that is from the STENO2 trial, and we have heard the importance of addressing the multiple risk factors. So it's just not the glycemia, it's lipids, it's blood pressure. And as you can see here, these were the results at the end of the STENO2 trial. And it was clearly demonstrated a huge reduction on stroke, myocardial infarction, PCI, vascular surgery, amputations. But there were no clear demonstration that with that, we reduced the number of cardiovascular deaths. And just as a word of caution also, if you see the top left panel, you can see the difficulty to achieve the glycemic goal that was less than 6.5% for that population. But it was easier to achieve lipids and blood pressure. So just a reflection for you, for your own practice, how much are you trying to address all these risk factors, or are you still targeting the glycemic control, which we all know that's difficult even in very hard conditions as were those of the STENO2. But also the STENO2 had a follow-up study. And as you can see here, we had, after the end of this follow-up study, you can see still the reduction on stroke, myocardial infarction, revascularizations, amputations, but now it was quite evident to reduce number of deaths from cardiovascular causes, meaning again that keeping patients well treated from the beginning, sometimes we need to have time to show the benefit on some of the outcomes. But then we know that's not about just lipids, and it's just not about insulins, it's just not about metformin and sulfonylureas, and we know all that we have a lot of new drugs, and we all have heard now the data on these new therapies. But if you just check the guidelines from Diabetes Care on 2006, it was quite easy. So 15 years ago, after lifestyle intervention and metformin, either we choose basal insulin, add a sulfonylurea, or add a glatazone. That was quite easy, as you can see. 2 years later, we tried to complicate a little bit with those well-validated therapies and less well-validated therapies, but there were not so many choices. That was 2008. And then we also had those results that were also a surprise at that time, not a good surprise as the results we have heard today, but the surprise of the ACCORD trial and even of the VADT, showing us that it was not all about reducing glycemia. It was not always to have the best glycemic control, because for some, at least for a group of patients, that would increase mortality. And as that, we had to be cautious again about results. Sorry. And then we don't know, because most of the studies don't compare the efficacy of all the groups that we have now available to us. And so it's quite difficult when we see this kind of presentation, as I'm showing now, we also know that perhaps insulins are the most efficacious drugs for reducing A1C, but we know that's not always the case even now when we introduce the new drugs. It really depends on the starting point of the A1C, even on the context of the patients. And so it's difficult to analyze data because sometimes we don't have the data for that. And with that, we know that those are the guidelines from 2012. We know, again, we have the healthy eating, weight control, increased physical activity, and metformin. And then we try to decide what aspects were more relevant for the patient. It was the efficacy, lowering A1C, hypoglycemia, weight, side effects, costs. And again, considering that, you had to choose between sulfonylureas, glitazones, DPP-4 inhibitors, GLP-1s, insulin, and at that time we didn't have the SGLT2 inhibitor, so 9 years ago. But then we arrived to the present, and either Dr. Chen and Dr. Mehta have shown these guidelines from 2021, and we try to say that it's a more personalized approach. And why is this personalized approach? Because we have on the left side, we have the group with high risk, established atherosclerotic disease, chronic kidney disease, or heart failure. And on the right side, we have the other patients. And my question to you is, do we have other patients? So we have are people with diabetes at a lower risk, at intermediate risk, or should they all be on the left side? And for that, do we have evidence that they should be treated all according to the left side? But just also to remind you that the WHO has just recently published the new list of essential medicines, and at least the SGLT2 inhibitors are now part of the list, and as are some of the newer insulins. So again, it's the relevance of data. It's also pushing WHO, that is supposed to push governments so we can guarantee access to these new drugs also for the patients for people living with diabetes. But again, those guidelines probably are well known for all of you. And the problem is now the next part. So what do we do as healthcare providers? And if you see those boxes, it's like if 80% of the healthcare providers are aware, if 80% of them accept those guidelines, if 80% apply those guidelines, and 80% are able to apply them, and 80% act on the needed patients, as you can see, we are now the numbers that less than 50% of the patients would benefit from the evidence produced by guidelines. Why is that? Because of that process that also Professor Chen has already spoke, that's about knowledge translation. So how is knowledge translated not only to research, but to clinical practice? And if you see those 5 points just on the lower part of the slides, sometimes it depends on how you design the guidelines. Again, imagine, I've shown you ADA, EASD guidelines, and I bet that many of you that are listening to us don't live either in Europe or in North America. And so we have an immediate doubt if this evidence, does it rely to our population? Can we act in our population with these drugs? Do we have access to these conditions? So are we as end users used for the translation of knowledge? And then are you using the right strategies to let the guidelines be known and implemented? This is just a curiosity. It's about the use of the local opinion leaders. And I hope that many of you listening to me now are what we can say, it's local opinion leaders. So, and that's just seeing the last two lines here. Local opinion leaders alone or in combination with other intervention can be effective in promoting evidence-based practice. But again, the effectiveness varies both within and between studies. There are not so many studies, and it's quite hard to have a good methodology analyzing that. And what about the clinical inertia? And I know that many of you have heard about this. So what do we call the clinical inertia? That's our failure as physicians to initiate or intensify therapy in a timely manner. And for that, we can address three conditions. Clinical goals or targets are recognized, and we know that's usually the case. And there is a recommended therapy that can be used to achieve the clinical goals. So again, the question here is, do we have access to these recommended therapies? And the third point is the time frame appropriate for initiation or intensification of the therapy. And so let's see if what we do in our regular life, in our daily life if we have the conditions to fight clinical inertia. So do you all know there's an implicit or explicit guidelines? Are we aware of the guidelines? Do we believe that the guideline applies to our patient? Do we have the resources to apply the guidelines? But even if those conditions are all met, do we, as physicians, follow the guideline in the case of this patient? And we know those are the results from the United Kingdom. And as you can see, the mean A1C at intensification with one oral drug to 2 or 3 oral drugs, or even to insulin, the starting point for changing the therapy was 8.7, 9.1, or 9.7. So just check how different it is from our recommendation. And we know that old people speaking about diabetes who are always discussing what's the good A1C, if it's 8, 7.5, 7% or less than that. And actually, we just took actions starting at 8.7, 9.1, or even 9.7. And we have more than 5, 6, or 7 years to take another decision on that. So it's just not a question of knowing, it's a question of action. And for that, we can, even with the drugs that we have access, we are putting our patients with an avoidable glycemic burden. So it's all the time that they are above our A1C goal and all the years that pass without changing our attitude. So again, should we speak about this? And what outcomes? Diabetes, and you've heard the two previous talks about, it's also about mortality, even about complications. And you can see that those were the results published for the United States, with showing us an increase for the last years in mortality, especially in the younger groups. And it's difficult to see here on this panel here, but diabetes is also increasing the mortality, especially at younger age. So again, in some parts of the world, life expectancy is decreasing, and diabetes is part or only a marker of the problem. And the same could be true about complications. And I know that there's some discussion about these results here, but again, even if it's not stable, some of the complications were increasing here, and especially again at younger ages. So again, what are we doing? Are we forgetting some of the complications on diabetes? And we have heard about clinical trials, and those were the results of the clinical trials with dapagliflozin, one of the studies here. And I just want to show your attention to this part of the table, that most of the patients were quite heavily treated, because we know that's important for reducing out the cardiovascular outcome. So we have 80% or more on ACE inhibitors or ARBs, 75% on statins, 40% on diuretics, 60% on antiplatelet drugs. And so what happens with that? So we know that, again, if we have this kind of population, a very well-treated population, we know all the results that Dr. Mehta has just shown us. And the question is, what happens in real life? Well, actually, even when we know that in our real life, our population is not so well treated as in clinical trials, nowadays we have access to other kinds of evidence. And this is an example from the CVD Real. So collecting real data from the real world in many of the countries, and those are the results about using different SGLT2 inhibitors or oral drugs. And it was possible to demonstrate with new data analysis tools that there is evidence in favor of the use of SGLT2 inhibitors. So I want to address that with that, we want to have access to the new drugs, but we cannot forget treating the patients targeting the other risk factors. And then a question about sometimes when we don't know the evidence. This was quite an important study because it was one of the few studies that were comparing two classes of therapies. So it was DPP-4 inhibitors, and as you know, we are not speaking so much about DPP-4 inhibitors, comparing with the sulfonylurea. That was the Carolina study. And there was no difference. So sometimes when we don't know the things, sometimes because the studies were not done, and when we don't have the data, we don't know the conclusions of that. And we have to be cautious when addressing those issues. And my final part of the talk, it's about something that we all forget, or it's more difficult to act on. That's this putting the patients at the center of the care, prevent complications, optimize quality of life. And those are again from the ADA Guidelines 2021. And all these are quite important, but most of the time we'll be discussing about the new drugs. And for that, I want to stress out that diabetes is also a risk factor for depression or even for suicides. And we often forget about that. So what are we doing with our patients? It's all important about heart failure. It's all important about chronic kidney disease, microvascular complication, but it's also about quality of life and mental health. And so what are we doing in therapeutic patient education? I work at the APDP, the Portuguese Diabetes Association, the oldest diabetes association, and we are very keen on these issues of therapeutic patient education. And I want just to remind you about this report of WHO, that therapeutic patient education are those set of educational activities essential to the management of pathologic condition as diabetes, managed by healthcare providers duly trained in the field of education, and designed to help the patient or families to manage their treatment, prevent avoidable complications, while keeping or improving their quality of life. And again, I want to ask you, and I'm not reading that part here because of the time, but I want to ask you if you are pressing your government, if you are pressing your local authorities to have access to the new drugs, and are you pressing the government or your local authorities about the access to therapeutic patient education, about having trained teams doing this? Is that your reality too? And finally, I think Professor Shen said to us that diabetes is really a societal problem. And this was published at the end of last year about diabetes like COVID-19. It's a wicked problem. It means that purely scientific solutions to societal problems are doomed to fail. And diabetes, we should try to address personal, consumer, physiological, behavioral, psychological, environmental, genetic data with social preferences. If we can address that, then we'll have a pathway to success. Just to remind you, and Professor Akhtar Hussein said that at the beginning, and all of my predecessors here have said also, even if we discussed the access to the new drugs, we are not discussing the role of education, and many of the people in the world are still not having access to the most basic therapies, to the most basic technology to have their best outcomes. And that's why IDF, for the World Diabetes Day, had several messages about access. This is the case about access to insulin and the relevance of achieving at least access to the basic things and to the conditions to provide those therapies. So again, when we speak about guidelines, don't just focus at the beginning, at that triangle. Try to understand what's your role as a healthcare provider and try to know people living with diabetes, the last three squares there on your right, where again, for the 80%, if you do all that math of 80%, you achieve with 22, 23% of people living with diabetes adhering to the guidelines. That's quite the same number as in real life. So, last slide about building guidelines. And you have to note that when we have no data, don't take just a jump conclusion of what that means. Use the right strategies at your local level to implement the guidelines. Try to realize what's your level of clinical inertia and your teams. What's the cost of that, even for the drugs that you have access to it. And when discussing outcomes, try to see where's the patient, what's the patient role on that. And thank you for that. With that, I conclude, and I think we'll have Professor Juliana Chan addressing the last points here.
Thank you, Professor Rapasso, and also, Dr. Mehta for this, very inspiring talk, regarding the latest evidence, but also, where is the gaps of implementation, and sometimes we also have to look beyond just these clinical outcomes, but really looking at the patient as a person. And there are other aspects, and not just the heart and the kidney, but also, the mental health, the self-management, the quality of life. But at the same time, we as healthcare professionals, also need to be advocates, because we understand the evidence or the gaps of evidence, and we know what the patients need, and how do we make other stakeholders, aware of that, and also, to drive the decision makers, the policy makers, the payers, particularly the government, to make that happen. So we have a couple of questions actually from the audience, from the delegates, and I would like to see. Would like to invite our two speakers to address them. So. Question is one of the questions is actually from Algeria, and that is the combination of SGLT2 inhibitors and GLP-1 necessary to protect diabetic patients with high CVD risk? So may I ask Dr. Mehta to really answer this question? So do we need the combination? You have to unmute yourself.
I was on silent. So, logically, we would think that I've shown that both agents have cardio-renal metabolic benefits. So you would logically think, even though we don't have the data, that giving both classes to our patients, we're going to achieve the best result. We have studies where one agent is added on to another agent, but we don't really have data with respect to CV outcomes when we have both these agents on board. My initial real reaction is that, of course, and starting these agents earlier is probably in the best interest of our patients, if it's possible. Access, cost, these are always issues in our regions. However, I also want to just stress, and I think throughout this session, we've stressed the importance of covering the other aspects of management. It's an integral care. We need to manage weight, we need to manage lipids, we need to manage hypertension. So all of this we can do quite easily if we actually avoid clinical inertia and help our patients really meet their targets in all of these variables. So that should be the first step. And then I think, yes, these classes would benefit. We don't have really the evidence to say, but if we look at it in the sense of what the evidence, the direction in which it's going, it does suggest these will help. But remember, integral care, personalized approach. Thank you.
I think this is really very important because the condition is very silent, right? And we really are dealing with multiple risk factors. And we talked about this clinical inertia. And I think we just need to think a little bit how within our context that we can actually systematically measure some of these risk factors, right, in order to try and reduce clinical inertia. And then you really give these basic medications, which can already create a lot of impact. And then if we can actually start measuring some of this outcome, and I think we're now in a digital era, and I think, if we start having this kind of system put in, we will be able to answer use of the real world data to answer some of these questions. For example, do this combination therapy really, achieve a better outcome? Because we can have so many clinical trials, so much, but ultimately, we really need some of the real world evidence to back it up as well. So I think both of them are very complementary. So, another the same theme, and so may I ask Professor, Rapasso to really answer this question, and that is how big the issue of treatment compliance or non-compliance for that matter is in your experience?
Well, I tried also to address that during that part. It's between our role as healthcare providers and the patient side here. we all know, we have been, and most of us, when we follow people living with diabetes, we say, okay, this is a good patient, that's a bad patient, when they don't follow our orders. And that means, again, that we are not doing our job in a real world, because it's just not just a question of giving information. It's just not a question of prescribing the right treatment. It's a question of knowing the patient. And that's how probably the most important things that we can do as healthcare providers. Otherwise, just knowing the guidelines and prescribing according to the guidelines, that's the easiest part, depending on the context here. So compliance means that we should address the issues. Why don't the patients do or follow the recommendations? And the easiest example, it's about lifestyles. We know that's the most difficult part. So, and sometimes it's also about the expectations on the drugs. And as you were mentioning, Professor Chan, it's a silent disease. So we are prescribing things that usually are unacceptable, or even sometimes providing nausea, providing hypoglycemia. So we are putting people that are feeling normal, and we are trying to frighten them with complications, late time complications, and prescribing things that they don't need. They don't feel the need to do that. That's why I try to address that last point about therapeutic patient education. It's about motivation. It's about trying to find how to put people living with diabetes on the right pathway, and the right pathway had to be chosen by them. Otherwise, we'll be spending a lot of money, governments will be spending money, people will spend money, but not taking the right things. So try to know the patients, try to use behavioral techniques, try to be doctors and nurses. That's the most important part of our job.
Yeah, I cannot agree more. And I think it is really important, while we have a lot of these educational talks about some of the latest evidence, we really need to continue to promulgate this very important, this fundamental, really, I think, self-management, and our role as healthcare professionals. I think, sure, sometimes the nurses are very good, but we as healthcare professionals, particularly as doctors, I think we need to have that leadership, right? Recognizing that importance to help patients to live with diabetes for really 30, 40, 50 years. And I think, sometimes when you see those data that you nicely show, you are now seeing the falling, the decline, the death rate or complication, but it is coming up again, right? This is a very, very worrying trend. And maybe sometimes we just have to get back the balance that sometimes, particularly for these young people, and I think a lot of these young people are actually very literate now. This is again, It's not like even in some of the developing countries, we have actually general education. The overall literacy is getting better, but the health literacy is still lagging behind. So until we have all these working in parallel, right? We educate our patients, we educate our healthcare professional, then we will really bring out the best of these medications.
And I think we understood that during the COVID pandemic, even that concept of the health literacy, about taking the right options, and the importance of information, the importance of, at least in my country at the beginning, when people were so afraid that everyone stayed at home. But then that's when we have the diagnosis of diabetes. Sometimes we are just afraid. But after 1 month or 2 months, when nothing happened to you or to your relatives, then we try to go back to your ancient life, to your previous life. And that happens also with diabetes.
Yes.
Yes. So another interesting question from a nephrologist and from Cambodia. So this is really very international. Again, congratulations to IDF for putting this together. We really have a very international audience. And that is actually how to consider the ethnic group differences while deciding the medication. Sorry, this one is from Tanzania. And then the other question is if we have middle-aged person who is already on multiple drugs, oral drugs, and A1C is at goal, should we start GLP-1 or insulin? So maybe I'll throw the questions to Dr. Mehta first regarding this middle-aged person on multiple oral drugs, A1C at goal. Should we be using GLP-1 or insulin?
So I think here, again, individualize your treatment. The guidelines suggest that your first injectable should be a GLP-1 receptor agonist, but there's a caveat here. If you have someone who's decompensated, who's got polyuria, polydipsia, is losing weight, then insulin would be the first option in this patient. So there isn't a recipe for every single patient. And another, a GLP-1 may be the best option for the patient, but if the patient says, no, my brother was taking it, he had a lot of nausea, I would prefer not to take a GLP-1, I would prefer insulin in this case, then we have to discuss the pros and cons of both and come to an agreement. This is what the new guidelines are telling us, right? It's a personalized approach in which we foster this relationship with the patient. There isn't one recipe for every single patient.
That's right. Every patient, with diabetes is really different. Every person is different. I think we cannot actually emphasize enough, right? And behind that person, there is a story, right? They all have the different value, the perspective, and the way of doing things, some of the barriers and enablers. So, I think Dr. Jose was saying really nicely, you really have to know your patient. You know your patient, then at the same time, you also know the medication. And then, you have the right match. And exactly. I think you will be doing a great deal for the patient if we can really make that happen. And we understand there are also examples of care models, which have been shown to work, and I think this is really where the Lancet Commission also comes in. So I think it's really very nice that we have multiple viewpoints in this very unique webinar. Mm-hmm. So,
just
Dr.
let me tell
Raposo,
also
what
that
do you
I
think
think
about...
Yeah, I was just saying that sometimes we should also be humble as healthcare providers because we don't know everything. Even when we speak about type 2 diabetes, I think it was you, Professor Chantet, just mentioned, type 2 diabetes is so heterogeneous. There are probably so many subtypes of type 2 diabetes that when we try to address that and tell the same recipe, even in the most personalized aspect, but we actually don't know why some people are more prone to some kind of complications than the others. Yeah. It's not always about glycemic control. It's not always about lipids. It's not, and we don't know that. And we have to live with that. And that's also difficult for us because it's difficult for the healthcare professional to assume that sometimes we just don't know things.
That's right. So I think, for example, I think in Europe, the European Diabetes Foundation, right? They're now advocating, again, way very much in line with what the Lancet Commission report was saying, that we hope to have registers. We can make sure that these people are not lost to follow up, so everybody could have, even a name list is important somehow, right? You register your patient, get some basic data, and then the next thing is really the self-management, and nowadays we have all these variable finger pricking, and then finally this integrated care. Because I think with that is really, then you will be in a very much good position to use these tools and, the educators, for example, and not just the doctors, but really the doctors trying to train other educators. And then we work as a team and delegating the responsibilities, all focusing on the patient's well-being. At the same time, with those ongoing data collection, we can also learn, from the data. So I think it makes it actually more fun as well, right? Then you can actually start seeing, the heterogeneity, positive results, and how we actually, continue to improve. So, Dr. Raposo, what do you speak to that into the ethnic differences? How do you see, for example, the ethnic differences regarding to some of these drug responses? How would you address that?
That's for me quite a difficult question because, again, that's when we don't have so clear data about anything, even about the concept about the ethnic differences. We all know, and the discussion now, it's about even the concept of those differences. What do they really mean? Are they genetic differences? Are cultural differences? Are environmental differences? Social differences? So what do we mean with that? And as we know, these are quite new aspects on the discussion of focusing on the results and considering all those differences. 10 years ago, we were just discussing about Caucasians, Afro-Americans, Asian sometimes, and then it would be, and then the rest of the world would be in the same pocket. And now, even we don't know exactly what does it mean being Caucasian. I'm speaking about myself. So living in the south part of the Europe, quite different from the north part of Europe, and we have quite different results in cardiovascular results. We have here in my country, we have one of the highest rates of stroke as the main cardiovascular outcome, while myocardial infarction is much higher in the northern part of Europe. So it's not a question just about ethnical group, it's about many other things. So again, Professor, I would love to say to you what's the best evidence to show how to treat different ethnical groups. I don't know. I don't know if anyone knows that. Again, because even it's the starting concept, it's difficult. And I think we have to be cautious. When we don't know, I think we have to do the best thing we can do based on the evidence. And sometimes it just means that, and we know that on diabetes, we try, and if it goes well, it's perfect. If it's not going so well, we try a different thing. The problem with us in diabetes is that sometimes we're just adding steps on top of another step. We seldom do taking the last drug and introducing a new one. And it's just not about diabetes, it's hypertension, it's the lipids, it's the antidepressants, and then people would be taking so many different drugs. And we even, for that, we don't know what's the end result of using all those. So we still have a lot to know and a lot to apply, I think.
That's right. I think, this ongoing learning, right? Learning and living, right? I think it's the same for everybody. I think in the field of diabetes, there's so much to learn, right? But the good thing, it is actually compared to like 20 or 30 years ago, right? The science, the knowledge has advanced so much, right? Yeah. And I think, we always want better, but in a way, we have really, I think, the quality of life, the lifespan, etc., have improved, but it's just that it's such a big problem. Maybe this is all the globalization, all the urbanization, and then, it's just all part of a bigger problem. But as you say, what we know now, we should make it happen, because we know if we do it well, we're going to make a big difference to these people, right? I mean, prevention is the key. And I think with that, I think we really had a very interesting, webinar where we talk about the latest drug management, but also, how do we actually make things happen? Where are the gaps in terms of the knowledge and the practice, and a bit more philosophical kind of also, issues, which I think is really very important, because, we have to take into consideration the world is a very diverse place. We are dealing with different people, different cultures, different systems. And it is this, one good thing that's from anything that comes out good from the COVID is actually, I think, the internet, these webinars, have been really accessible. It make it easier for us to interact and to learn from one another. So I just learned that we now actually have 450 participants from 75 countries. And this is really exciting, really from high, low, middle income countries. And so with that, I would really like to invite, Professor Hussein to say a few words, okay, and, before we close the webinar.
Thank you. Thank you, Professor Chen. And it's a great pleasure. And first of all, I would like to thank the audience to be patient and to spend the weekend to listening to us and be a part of us. And I hope that this time was, this educational approach to you all was beneficial to all of us. And so I would also like to express my thanks to all the speakers. I think Professor Chen, Professor Rapo, and Professor Mehta, and I think you have provided the updated knowledge. But what you have discussed in this, I think in concluding remarks, I would like to say that we need to understand that diabetes is a societal disease, as Professor Chen has said. So it's not only the one aspect of the disease. If we have to treat people with diabetes, we have to see the totality in the context where this patient is, that is the society. And we cannot address more accurately without only by the guidelines, without looking at the patients. and its context. And this is important. So there are also some questions that, as you know, that IDF is very much interested in patient education, that which was emphasized very much here. And we are also, IDF schools are also opening up one special course for patient education. As you know, that IDF school has different courses for different arenas, but we are introducing a new course for patient education. So this would be one of the things. And I would also like to mention here that the discussions that also came up in terms of ethnicity, which actually interest me a lot. And I think that we also in future in IDF guides, we will try to address this issue, but it is a complex issue, as we have discussed. It's not an easy issue. We have also published a paper recently on the 100 years of insulin use, and that where myself and many of my colleagues from the IDF, and also colleagues actually from, we have from 13 different countries, that we wrote this article about the insulin therapy and the challenges by ethnicity. And I would also like to mention here that in the next, as a continuation of this series, the next one will be on the 20th of November. And the title would be that managing cardiovascular and renal disease in type 2 diabetes patients. And it is also it is also quite interesting to see that we started that diabetes, that is the glucose, is a continuous. And then the reason that we are controlling it is to control the complications. But what we are saying today, we are moving, I think we are targeting the complications first, and then we are reversing that, whether it will have an effect on diabetes as well, in glucose lowering as well. So it is quite interesting to see that how the treatment and the guidelines are actually moving in what direction. And the IDF is definitely following this very closely, and all your collaboration and all your support, IDF would be very much grateful to you. And I think that IDF school will communicate with you to have your guidance, to have your support for the development of our next curriculum, and also our guide in future. And I would also like to mention to the audiences that you, soon after that, when you close it, you will receive an email from the IDF Education Committee. And then I would request you to submit your evaluation or comments. That would also help us to improve our next seminar. And you are also able to download your certificate of attendance for this conference. And with these words, thank you all and wish you a very great weekend. Thank you.
Thank you.
Thank you.
Bye-bye. Thank you very much. Thank you. Bye-bye. Bye-bye.